Okay, thank you all for having me so much. Suzanne, thank you for asking. I appreciate the opportunity to talk about this. I'm going to put this in presentation mode. This fellowship was begun about 3 years ago. So I do this introduction. Certainly much of what I'm going to say, you all as an audience are very familiar with. But I always like to start out by talking about the prevalence of disability in the US. And I love this slide from the CDC because it shows the different disability types. But what always has impacted me personally in being a professor in baccalaureate education is that we're not focusing on a quarter of the population, and we don't have this as a core curriculum for undergraduate students because it's 1 in 4. It's a quarter of the population. So certainly we all know as an audience and those that care for people with disability that they are a vulnerable population. Of course, this is quite old. We have obviously a lot of documented disparities and barriers, including inaccessible healthcare facilities, communication issues, lack of adequate medical information, and just healthcare providers simply not understanding that their disability, people with disabilities. A lot of overshadowing, diagnostic overshadowing, where physicians, even nurses, attribute symptoms to the disability. And I love this graphic because it really shows you sort of this inverse Maslow hierarchy that I think everyone probably in nursing school in our era was introduced to baseline foundational needs. But I like this because it's inverse. And it starts with the healthcare environment not being conducive to people with disabilities. And then it really drops down to the provider, where there's lack of disability training. There's already existing poor attitudes and incomplete knowledge of care coordination. And that's where we really get into the interprofessional piece and why teams are so just immensely important to caring for this population. So of course, the aggravating factors that contribute to the barriers for people with disability is not just the negative attitudes, but inaccurate and inadequate knowledge, lack of educational preparation, and limited skills in diagnosing, treating, and providing care. And then, of course, that contributes to the disparities that Sarah was mentioning earlier and quality of services for people with disability. So we know that education reverses these attitudes, and it doesn't only just reverse the attitudes of students or care providers, but it builds confidence. So I'll speak to a lot of the testimonial information I have collected in the various cohorts of students I've educated. And it's interesting because they say, gosh, we're not exposed to this in nursing school. But now that I've taken this and participated in this fellowship, I feel more confident. I feel like I can communicate with people with disability, particularly intellectual disabilities. So we know it positively impacts those negative attitudes. It reverses them and it builds that assurance. We also know that frequent and repeated clinical exposure of care of people with disabilities is successful in building confidence. So I don't need to tell this audience all the different factions, but I always like to bring this as just leverage to why we should integrate education as core curriculum in baccalaureate education, disability education. We have, and I apologize for that. We have a variety of factions: Healthy People 2020, the WHO, Institute of Medicine, which is now National Academy of Medicine, Surgeon General, National Council on Disability, and the 111th Congress, all that have really urged for inclusion of disability education and healthcare provider training. So in 2008, I was the only, now to my story and how I developed this fellowship. In 2008, I was the only faculty who was coordinating a community clinical, which is required curriculum for baccalaureate science of nursing, baccalaureate undergraduate education at clinical sites that serve people with disabilities. And at that time in 2008, I had about 5 different clinical affiliations where I would take students to. So the dean at the time and one of the development team members who manages endowments and benefactors approached me with a benefactor who wanted to give money to our school specifically. And specifically, this benefactor's overarching goal was just simply to educate students with disabilities. There were no other specifications. To back up, the dean at the time had a child, and sadly, that dean went on to Columbia University. Sadly, her daughter, who was in a group home with profound disabilities and nonverbal in Houston, she just recently passed. And so she had her own reasons and for really pursuing this benefactor. So I initially pondered, I just sort of had the sky's the limit given to me to write this endowment. And so I pondered, gosh, maybe this should be a graduate certificate course. So I went and I interviewed all of the graduate track directors in all the various specialties. And even one of my dearest friends, who's an emergency nurse practitioner, she said, you know, Allison, not everyone wants to do this kind of work. And I'm like, you know, you could run, but you can't hide. I don't care if you're in the ER. I don't care if you're in a NICU or an ICU or an IMU. You're always going to encounter somebody with a disability. And it's imperative that students know how to not just care for them, but to communicate with them. So I really had this reversal and this 360 where I was thinking this should be graduate level education. I just had an epiphany. I said, wait a minute, I'm looking at how undergraduate students react to people with intellectual and developmental disabilities. What am I doing? This needs to be embedded in our core curriculum, ideally, but if it's not, it needs to be a co-curricular opportunity that we offer to undergraduate students. And so then the wheels really began to turn, and I thought, you know, I think at the senior level, at the 3rd semester of nursing school in their upper division, after they've had a good foundational psychology course and clinical and some exposure to patients, that would occur in the 3rd semester. So we're just really a 2-year school. Our students get their prerequisites elsewhere. So that's in 4 semesters that they get their BSN. We are year round, so we're fall, spring, summer, and we individuals apply at each of those terms, fall, spring, and summer. So I developed the curriculum as clinical immersion, really just to expose undergraduate students in that 3rd semester to people with disabilities. And because we know how the ADA defines disabilities, it's quite broad. So I really thought, okay, I need to ramp up my clinical affiliations, interprofessional experiences. So I really got busy and hit the ground running by ramping up primary, secondary, and tertiary care affiliations. So I framed this as an independent study. So there would be no minimum required student participation, as opposed to like an elective where I would, if I was going to offer an elective, I would have to have 10 students every single time I offered it. So I didn't want that to be a barrier. So I framed it as an independent study. And then I attached a $2,000 stipend to offset the 2-hour credit of this 90-hour clinical immersion they would get, which would essentially cover about 3/4 of their tuition for their 3rd semester. I advertise applications and open them to the 2nd semester students well before we begin the 3rd semester. And I've opened those applications, which is online, it's Qualtrics. It asks about their experience with people with disabilities, which is not a prerequisite. but it asks a variety of questions just about why they're interested in the program, because I'm really trying to get away from the money. The money helps them offset it, but where tuition typically runs about $3,200 in the third semester, helps them offset it, but I didn't want it to be an incentive. So it was really tricky determining that financial stipend number. I do offer the fellowship only in the fall and the spring because the summer is super compressed. We're about a month shy of a regular semester in the summer, and I felt like core curriculum is what we needed to focus on. I don't want this co-curricular opportunity in any way contributing to their demise in the program. So there are eligibility requirements, and that includes a 3.5 minimum GPA, because this brings them up to 18 hours in their third semester. So their core curriculum is 16 hours. It's a 2-hour additional. So I need to make sure that I've got a solid student who is certainly able to handle that additional 2-hour clinical immersion. And then they interview with me, where I go through their application. And so there's an online, then the eligibility requirements, and I confirm all of their GPA, make sure that there's no withdrawals and that they're a solid student, and then the interview. And I advertise this through email, as I said, to the second semester students, to our peer tutors. And then I also, during the second semester, during their OB-GYN core curriculum, a really good relationship with the faculty. She allows me time where I bring former fellows to provide testimony, talk about it. I talk about the application and the process, and then they talk about the experience. So that's sort of how I have advertised it, with the addition of there being a outward-facing co-curricular opportunity on our intranet. I know this is super hard to read, but this is the curriculum. I can put this table in the chat box when I finish the presentation, but we spend an entire day, just to give you an idea of how that 90 hours is comprised, because it is clinical. So for every 1 hour credit, they are really doing 45 hours of hands-on care. So that's 90 hours. In the very first day, I have an orientation that includes communication etiquette, ADA, prevalent disabilities, comorbidities. We do a little autism quiz on Kahoot that was a CME. I have a PowerPoint that I go through the most prevalent disabilities. And again, it's very overarching. It's acquired disabilities, it's intellectual and developmental disabilities. So it really tries to reach the whole gamut of disabilities, as does the 15 clinical affiliations. And then for about 2 hours, they'll spend onboarding with the various facilities that we have a clinical affiliation with. All the HIPAA, a lot of it's very redundant, but each clinical affiliation requires something different. I then have them do a reflection paper about the disability experience. Before they even begin the disability, when I do onboarding, when I do orientation, I have them do the implicit bias test that Harvard has, that's disability specific. So I do that in the beginning, and I do that at the end of each fellowship to see if their attitude has changed. And once I get past the next 2 publications, I'm going to get research approval to do that and use that information to show that this 90 hours does change their attitudes. So where they may come as neutral with no preference to people with disabilities or without, typically that changes in a positive way. So they do that implicit bias during that introduction. And then I also have them do the online modules for onboarding. This is just preliminary preparatory education before they even begin the clinical experiences. I have them do the CDC online modules, part 1, which is people with physical and sensory disabilities. And then part 2 is people with developmental disabilities. I also have them do the Fatal 5, which formerly was with the Ohio, but they've cut me out of that now. So I've had to purchase an online platform that is through Intellectability. So I'm now using that one instead of the Ohio-based Fatal 5. Then about 64 hours of clinical practicum, and that clinical practicum I'll discuss in detail on the next slide, how it integrates with interprofessional education. And then the only thing that they are really graded on, besides being a completion component of the fellowship, is they do a case study. They do a deep dive of any patient they've experienced during the fellowship. There's a rubric, there's prompts, there's questions, and then they present that to their peers and to me, and then they're graded on that based on the rubric. So that case study presentation consumes about 3-hour preparation time. And then I'll give them weekly debriefing questions about their experiences in the clinical settings. So the total fellowship hours really culminates to 90 hours. So I have integrated this in their required curriculum. The required curriculum in their community clinical is more of an abbreviated rotation to different sites. And of course, they have a project. There's a different syllabus, a different grading rubric, which comprises 135 hours. For the 90-hour clinical, they experience just more intense hands-on with far more rotations. So I take them for primary care, and if you'll see the little star by each, that's where those are integrated interprofessional experiences. So we go to transition medicine clinic, which is primary care. This clinic is really an amazing, innovative clinic, started by a nurse, of course, turned MD, who once those 18-year-olds are kicked to the curb by their pediatrician, then they really have nowhere to transition with primary care physicians that know about disabilities. So this transition medicine clinic was created exclusively for people with disabilities. It's the way acute care should function. They have huddles in the middle of different clinic visits. Excuse me. I'm so sorry. They have a physician, a nurse, and an LMSW that rotates into the room and cares for the clients. We then also go to specialty outpatient clinics and tertiary care. Excuse me. We go to the Institute for Research and Rehabilitation, which is at TIER. We go to the urology lab. This is predominantly spinal cord injuries. The baclofen lab, and then the outpatient area where there's OT, PT, physicians, and RNs all working together. We go to the autism clinic, Texas Children Developmental Meyer Clinic, where there's a physician, a nurse, LMSW, and a speech therapist. This is new diagnosis and then follow-up diagnosis for autism. And then we go to the University of Texas Orthopedic Clinic, which is exclusively acquired disabilities amputations. And the physician, an RN, and a PT work together there. They do one rotation at Shriners Hospital for Children in Galveston. And the community care, we do 3 different schools: Arbor, Rise, and Monarch. This is predominantly under 18 years of age. There's physical, OT, speech, and RNs in that setting. And then community care, residential and day hab facilities, Center for Brookwood Jewish Family Services. And then Camp for All is a camp for children with disabilities. They also integrate into a inpatient setting during spring break and holidays. So that's a really cool camp that students go to. And then there's a post-high school graduate school for adults with Down syndrome, Friends of Down syndrome, that we also go to. So that just gives you an overview of sort of the broad array of clinical affiliations that I've procured and that students rotate to. So I think we have time for me to show you this link from testimony from the 4th cohort. We're now on our 7th cohort, and I've had 47 fellows participate to date. So I'm going to see if I can open this link by exiting out of this. 1 second. And so can everyone see my page still?
Yes.
Good. All right, so this is the co-curricular opportunity. There's 2 programs on this page. One is the ambassador program, which is like a leadership. This is just an overview of the program, all of the requirements, eligibility, program flyer, aims and objectives, and the fellowship application is here. So what I have done over 4 cohorts is, because peers listen to other peers. I could stand up and be a talking head all day and encourage students to apply to this program, but they're not going to listen to faculty members like they're going to listen to their peers. So I teamed up with our media people and internally, and we did videos for the 1st, 2nd, 3rd cohort, and I cut it off at the 4th cohort because I think at that point students who are applying will get the idea what a fulfilling and robust experience it is. So this is the 4th cohort, which was 3 cohorts ago. So I will play this for you now, and I'll enlarge it. I think I can, well, let's see.
Doesn't seem to be connecting. Allison, if you're going to or trying to get it linked through the slides, I'm not sure it's going to work. If you were in the slideshow, it might, but I don't think it'll do it separately, just in the slideshow.
I don't think that works.
Okay, so you're not hearing the video at all?
No, we're not hearing a video or seeing anything.
We're not seeing
Okay.
it.
Typically
Nothing.
doesn't work through a slide.
Okay, hold on 1 moment. Let me do this. I'm going to copy the link. I am going to go into the chat box. I'm going to put the link there. And then I'm going to try to play it through that. Let's see if that works. Do you think that'll work?
I don't know.
Okay. Try it again. No, it's popping over, but you're not able to hear.
No, we can't.
So probably you might give us a description of what's in it.
Let me
You
turn
need
it
to-
off.
You need to reshare and share
Ah, okay.
and make sure that you select share audio
Let me do it
and,
again.
and share screen.
When you share, select audio. Okay, so. let
And
me
then share
do
screen, the whole screen.
Share screen
Yeah,
and,
and share audio.
okay, share.
That should
And
work.
let's see. Let me make security. It says new share. So let's see if you can hear and see the video as well, right? Can you hear the student speaking?
No, but we can see
So
them.
you can see it, but I can't hear it.
Okay, interesting. Let's look again.
Well, the thing is that we've got the link, so even if you are not
Yeah,
successful,
people got the link in the chat so they can take
Okay.
a look at it.
yeah, we
They
can always
give us-
listen
Just give
afterwards.
us a description of what's in it.
Perfect. So you can look at the video there. I apologize. I'm much more familiar with WebEx than I am Zoom. So let me do this. Okay, good. Let me get out of these and let me make sure you can see. I'm going to come back to my screen here. Can you see the slide?
Yes.
Okay. Now I'm going to go back to presentation mode.
Okay,
We go. Okay, is that clear?
yes,
Okay, thank you. All right, so my research is qualitative and we are wrapping the number of themes that I've come up with is really unbelievable. I used Atlas 8.0 and it took forever to code all the data, but through all the various cohorts, we've really collected some really fabulous information. My overarching question is, does participation in clinical education impact the attitudes and confidence, and does it impact skills and knowledge? Now, obviously, I've got quite a few limitations because this is a singular institution experience. So there's selection bias because there's eligibility criteria, generalizability, obviously confounding variables, peer influence, and so forth. So I've got quite a few limitations, but still what I would consider, and from really experienced qualitative researchers, they considered it very robust information now that it's all coded. So we're working on our first publication now, and but there's so many more themes. One of the really experienced experts in qualitative research had shared with me that she said, you know what, this is 2 or 3 papers. And so we're just working on the first one now. The second one is we're working on the prevalent themes. So some of the things that are really interesting that emanate from the impact of clinical education is what I found interesting was students have this whole perspective shift. That nonverbal doesn't mean that it is correlated with someone's intellectual capabilities. And then the other interesting theme that comes up over and over again with students is how much variation there is within a diagnosis, within a disability diagnosis, within Down syndrome, within autism. They're just, rather than putting a client or a patient in this box, expecting all the same clinical sequelae, they are so amazed that they can vary and that they're individuals just like anyone without disabilities. Another thing that's really cool that comes up a lot is that they learn from the patients, and it really helps them change their overall bias. And I previously mentioned that their increased comfort really equates to increased confidence and competence, and improves their communication strategies, and they feel the overall experience is not just valuable and impactful, but it really is impacting their future professional development. So these are some Certainly, I put the link, the video links of the different cohorts that you can go back and look at the archived videos from the students and their testimony. But you can also look at just some of the sort of exemplar quotes. Cohort 1, one of the students said, I had such a bad misperception of disabilities. This really broke that bias for me. Cohort 2, pertaining to knowledge. This student said, knowledge is power, and I already feel more confident in my understanding of the resources available to people with disabilities. And now I can connect them. And this is something I really stress throughout the experience, is that even if you don't know the resource, we have the tools to do the resource and the advocacy for that client or for that patient. And we need to be their advocate by finding them the resource or connecting them with different people. Cohort 3, this quote pertained to confidence and competence. The student said the best way to overcome feelings of anxiety is to get experience with this population. The fellowship has made me a lot more confident in my abilities to care for people with disabilities. And so obviously significance of interprofessional education is, now I'm giving you the baseline Maslow's hierarchy. So I start with the reverse, where it comes down to the provider, and then how we're trying to change that level of education. We already foundationally have IPE competencies from the Alliance for Disability and Healthcare Education. And this fellowship was largely based on those, certainly in a more condensed way, but this is the foundational basis for the fellowship. There's also curricula from AADMD, the American Academy of Developmental Medicine and Dentistry. Currently working with the School of Dentistry now, a physician and also a neurobiologist, and we are looking at a seed grant to do interprofessional education, sort of using the clerkship model with the physicians and the dentists in the different semesters, and then with nursing students. So we are putting that together as we speak. And then as you progress toward more of the self-actualization, we address the health needs among disciplines with people with disabilities as a navigating team member. So I thought this was a really nice Maslow's hierarchy that ADHC produced from the AADMD interactive reports. And those are my references. Let me get out of the screen and stop sharing. I did want to mention that in the testimony that of the students, one of the students in cohort 4 recently took a position, was waiting for a position at Transition Medicine Clinic, which is the primary care clinical opportunity. And she just got a position there. So she was one of the fellows that rotated there. She was so inspired, knew she wanted to work there, had to just wait for a spot to open. And I got a text from her last semester that said she was working, she was starting to rotate in. So that was a real success story.
Okay. Allison, thank you so much for sharing all that information with